Vascular Anomalies, a review. Division of Oral and Maxillofacial Surgery, College of Dentistry, King Saud University. Introduction, Vascular Anomalies. Vascular lesions in the head and neck region can result in significant cosmetic problems for the patient, and some may lead to even serious life-threatening hemorrhage. Vascular anomalies. In the past, there has been confusion regarding the proper nomenclature for vascular lesions. In 1982, Mulliken and Glawotsky biologically classified the vascular anomalies of the maxillofacial region based on their clinical behavior and endothelial cell characteristics into two groups, hemangiomas and vascular malformations. Hemangiomas are the most common tumors of the head and neck in infancy and childhood, comprising approximately 7% of all benign soft tissue tumors. Development. Hemangiomas. The hemangioma is a true vascular tumor that results from the overgrowth of normal vascular tissue. It exhibits relatively rapid early growth until approximately 6 to 8 months of age, proliferative phase, followed by regression by 5 to 9 years of age, involutory phase. It grows by endothelial proliferation. During the rapid growth phase, an increased number of mast cells is seen within the endothelial wall. Development. Hemangiomas. The majority of the hemangiomas in infants are noted by the parent within the first month of life. Hemangiomas are initially noticed as an erythematous, macular patch, which progresses through a rapid proliferative phase whereby it changes its color and grows faster than the commensurate growth of the child. By the time the patient is 12 months of age, most hemangiomas have shown signs of involution. The process of involution is normally slow and will not be completed until the age of 5 to 9 years. Clinical presentation. Hemangiomas. Hemangiomas are found in the superficial tissue, the deep tissue, or both, and may affect organ systems such as the liver, lung, spleen, and gastrointestinal tract. Most superficial hemangiomas can be diagnosed by clinical examination and a detailed and accurate history. Clinical presentation. Hemangiomas. Deep hemangiomas involve muscle or visceral organs and are more difficult to diagnose. Therefore, further diagnostic studies are required. Intraosseous hemangiomas are extremely rare. However, the soft tissue lesion may deform the underlying skeleton. The predilection for females is approximately a 3:1 ratio. Clinical presentation. Hemangiomas. On examination, the superficial hemangioma usually consists of a raised, reddish to purple tumor with a distinct margin. In contrast, deep subcutaneous hemangiomas often have a deep bluish hue with normal overlying skin, making diagnosis more difficult. Both the lesions are firm to palpation and do not pulsate or exhibit any thrills or bruits. Investigations. Hemangiomas. Computed tomography, CT, scan, and magnetic resonance imaging, MRI, imaging techniques are used as diagnostic aids to document the extent of the deep hemangiomas. Investigations. Hemangiomas. Arteriography is rarely indicated for the diagnosis of hemangiomas. Management. Hemangiomas. Observation and parental support are the initial approaches in the management of maxillofacial hemangiomas. If functional compromise such as visual change, airway or masticatory compromise, bleeding, ulceration, or infection occurs, intervention is necessary. Management. Hemangiomas. This may initially involve corticosteroids for rapidly proliferating lesions or therapy with interferon alpha-2A. Surgery is generally reserved for small lesions and as a secondary procedure after initial therapy and involution. Treatment modalities include routine excision, injection of sclerosing agents, cryotherapy, and ablation using an argon laser. Vascular malformations. Vascular malformations are present at birth and, unlike hemangiomas, do not go through a rapid proliferative phase, and they do not involute. They grow commensurately with the patient. Vascular malformations, types. Vascular malformations may be capillary, venous, arterial, or combinations of these. Approximately 31% of these malformations are found in the head and neck region. Vascular malformations. Vascular malformations are divided into two categories: low-flow and high-flow lesions. Capillary, venous, and lymphatic malformations exhibit low-flow lesions. Arterial and arteriovenous malformations exhibit high flow and are capable of severe hemorrhage with significant morbidity. Development, vascular malformations. Vascular malformations are thought to result when there is interruption at a particular stage of development of a vessel. The type of vascular malformation that results depends on the stage at which normal morphogenesis is interrupted. Development, vascular malformations. Thus, vascular malformations are subclassified by tissue type into capillary, venous, arterial, lymphatic, and combinations thereof, with the type of malformation that develops depending on the type of tissue affected during abnormal development. Development, vascular malformations. Trauma, infection, and hormonal fluctuation, pregnancy or puberty, may stimulate increased growth of the vascular malformation. The mechanism of growth is not increased endothelial proliferation, which is within a normal range in these lesions, as is the number of mast cells, but alteration in the flow dynamics within and around the lesion. Development, vascular malformations. This results in recruitment of collateral vessels and dilatation of involved vessels. Unlike the hemangioma, the vascular malformation exhibits a steady increase in growth, without signs of involution. Clinical presentation, vascular malformations. In many cases, the diagnosis of a vascular malformation can be made from the patient's history. Although present at birth, these lesions are often not identified immediately, but only later on when the lesion enlarges enough to be clinically identifiable. This is particularly true for intra-bony lesions, venous malformations, low-flow lesions. Venous malformations are bluish, soft and easily compressible, and auscultation reveals no bruits. These malformations can vary from superficial, localized, mucosal spongy ectasis to complex invasive lesions that permeate tissue planes and alter the regional anatomy. Venous malformations. Any maneuver that increases venous pressure, E.G. Valsalvan maneuver or supine positioning, can temporarily enlarge a venous malformation. The clinical absence of pulsations or a thrill generally indicates a low-flow venous vascular malformation. Phleboliths that may be noted on radiographic examination are found only in low-flow lesions. Venous malformations, phleboliths. Capillary malformations, low-flow lesions. Capillary malformations may be smooth initially but become more pebble-like as the patient grows. Intraorally, these lesions are often comprised of lymphatic tissues and therefore take on an irregular, pebbly surface, sometimes called as salmon eggs. Capillary malformations, low-flow lesions. Port wine stains, telangiectasias and capillary malformations may appear pink in infancy and darken to a deep purple in childhood. Port wine stains, telangiectasias and capillary malformations may appear pink in infancy and darken to a deep purple in childhood. Capillary malformations, familial telangiectasis. Lymphatic malformations, low-flow lesions. Lymphatic malformations are normally colorless, however, Combined lesions take on the hue of the additional vessel type. Lymphatic venous malformations may appear deep purple while capillary lymphatic malformations can be pink to purple. These malformations can become invasive by dissecting along tissue planes and can cause bony hypertrophy, distortion or both. As these are lymphatic tissues, infections may result in rapid enlargement of these lesions. Lymphatic malformations, low-flow lesions. Arteriovenous malformations, high-flow lesions. Arterial or avenue malformations are high-flow lesions, which consist of a large high-flow vessel leading into a multitude of smaller lower-flow lesions. It is the lower-flow vessels which induce the development of the feeder vessels. Thus the resulting collateral circulation makes these malformations very difficult to manage. Arteriovenous malformations. Clinically these lesions appear stained, warm and tender to palpation. There may be swelling or asymmetry. A bruit may be detected. Arteriovenous malformations. Often a patient presents with severe bleeding as the first sign that a high-flow lesion is present. They may also complain of recurrent gingival bleeding and loose or depressible teeth. Investigations, vascular malformations. Many vascular malformations demonstrate few radiographic signs until well into adolescence, and a significant percentage will never show any bony changes. If the lesion involves bone, then a soap bubble or a honeycomb appearance is the usual radiographic finding. Investigations, vascular malformations. Magnetic resonance images, MRI, may differentiate low-flow from high-flow lesions. The presence of fatty deposits, venous lakes, phleboliths in the MRI are all indicative of low-flow lesions. CT scans document a lesion's extension into the surrounding soft tissue. Doppler imaging can also distinguish high-flow lesion from low-flow lesions. Investigations, vascular malformations. Arteriography cannot only delineate the size of the lesion, but can also assess the rate of flow through the lesion. Moreover, superselective embolization of the selective feeding vessels to the high-flow vascular lesion can be achieved simultaneously while performing the arteriography procedure. This procedure is usually done before surgery, in order to prevent the risk of serious hemorrhage during surgery. Management, capillary malformation. In the head and neck area, the argon laser has proven to be very effective in altering unsightly superficial blemishes that are caused by capillary malformations, port wine stains and other telangiectasias. Management, capillary malformation. It is important to remember that port wine stains may occur in association with lymphatic, venous or arterial malformations. Therefore, it is important that management of these cases be based upon the characteristics of any deeper malformation. Management, lymphatic malformation. Lymphatic malformations can prove to be more difficult to treat because of the poor demarcation and the infiltrative nature of the lymphatic vessels. Therefore, for the lymphatic malformations, several non-surgical modalities like steroid therapy, radiation therapy and sclerotherapy are available. Bleomycin sclerotherapy, O.K432 sclerotherapy are found to have promising results in the treatment of lymphatic malformations prior to and possibly precluding surgical intervention. Management, venous malformation. Some of the low-flow venous malformations lesions may cause bleeding during surgery, and therefore it is important to determine the lesion's size and flow dynamics with the help of arteriography before surgery. The treatment of a true low-flow venous malformation is based on the size and location of the lesion. Management, venous malformation. Sclerosant therapy alone has been shown successful for smaller malformations. Direct injections of sodium methylate, boiling water, alcohol, and ether block have proven to be effective in fibrosing these smaller lesions. Larger, invasive malformations have been treated with a combination of sclerosant and surgical therapies. Management: venous malformation. Kane et al. Have recently demonstrated significant patient satisfaction with sclerotherapy with tetradecyl sulfate, sotradecol, combined with conservative ablation. It is important to know that in most cases sclerosant therapy is purely an adjunct to proper surgical ablation. Management: arterial or AV malformation. High-flow lesions can have turbulent blood flow, introducing the risk of consumption coagulopathies. Therefore, proper preoperative hematological studies have to be carried out. Pre-ablation selective arterial embolization has improved the surgical success rates for arterial and AV malformations, especially the intraosseous ones. Management: arterial or avenue malformation. The goal of embolization is to decrease flow in the malformation while avoiding disruption of flow through proximal feeders. Any surgical intervention should follow within 24 to 48 hours of embolization, and never later than 10 days. It is believed that collateral flow to the malformation develops soon after embolization and that delaying surgery increases the possibility of intraoperative bleeding and postoperative recurrence. The goal of surgery should be total excision of the malformation. Management flow chart: vascular lesions.